Thanks, Colin. Tēnā koutou katoa. It's quite nice to come to Auckland. When the kids at home now, particularly the high school kids, when they talk about Auckland or say they're coming to Auckland, they actually only mean one thing. They actually mean the whitewater park out there. They're absolutely mad keen kayakers, and this, as far as they're concerned, probably that whitewater park out there is the most important thing north of Cook Strait. So I want to go and have a look at that sometime this afternoon. I can't stand up here and teach you how to do ultrasound. Again, that's a bit like that whitewater kayaking. You can only do that sitting in a boat with a paddle in your hands in the water. So I'm not going to even attempt to do that. I want to talk a little bit about pitfalls and scopes of practice. But mainly what I probably want to do is I want to talk about what is fundamentally different about clinician-performed ultrasound and how it's an integral part of our clinical practice. And so therefore I'm going to concentrate on those parts of ultrasound rather than that more traditional sort of ultrasound which you tend to refer your patients for. But even that has got some problems, because when I start to talk about that, then it's very dependent on your clinical context. And my clinical context is a little bit different to yours. So I'm still going to talk about it largely within my clinical context, and then I'm going to have to let you sort of translate that a little bit, a bit to your own. I mean, I've basically spent my entire career working where I grew up, and if someone plonked me in sort of in the city here in your context, I would probably feel pretty uncomfortable. Not as comfortable as if you put me behind a wheel and asked me to drive, but I would still probably feel pretty uncomfortable. Okay, so just a little vignette. So as an elderly lady presents to where I work, nothing specific in her history. Sort of a bit of weight loss, bit of malaise, but nothing more in history that you can put your finger on. So. But the one physical finding that was pretty obvious on examination was abdominal distension. And this is a quick look at her right upper quadrant with ultrasound. So what I'll do is I'll probably point to this screen over here, shall I? So some of you are probably a little bit familiar with these views, but this is her right upper quadrant, this is her liver, bowel, but what's very obvious is ascites. The next step for this lady was to drain that ascites, and having access to ultrasound has made an enormous difference to a lot of those procedures which previously a lot of us got quite used to doing blind, reliant on percussion and tapping out. So draining a chest or draining an abdomen is infinitely easier with ultrasound. So we could drain her abdomen, send the fluid away for examination, and she had very elevated CA125 and adenocarcinoma in that fluid. So there would have been at least one important step there where in the past that elderly lady probably would have had to go to the city. But we could talk to the oncologists and work through what the next steps would be with her and her family, which was really to do nothing. I think it was probably actually almost just the next morning on the ward, she was visibly short of breath. Not complaining of it, but she was visibly short of breath. And on this occasion, picked up the scan and had a look at her left upper quadrant. And you can see that this is her diaphragm and her spleen. And there's a bit of pleural fluid. We've still left some ascites in her abdomen, but this is a bit of pleural fluid here. So you think, well, was that enough to make her short of breath? But no, not really, because this is her lung. So it's not a huge pleural effusion. So I could sort of pretty much say, well, while there's some pleural fluid there, that's not really an explanation for it. But then you could have a quick look at her heart. Okay, and that's her heart. Now, I don't know how many of you are used to looking at these views, but the really important thing in here is the right side of her heart. This is the right side. This is the right ventricle. And the right ventricle should normally be a pretty narrow crescent-shaped structure, smaller than the left ventricle. But this is a hugely dilated right ventricle, and it's got this quite a distinctive box shape to it, especially to the apex of it, sort of up here. You could look at that immediately and say this lady's had a large pulmonary embolus, and that was the cause of her shortness of breath. And if you want to confirm that or provide a bit more corroboratory evidence, then you just have this is her right popliteal fossa, and that's artery, and you can see the probe. We're compressing with the probe, and the vein, this is the vein here, should normally compress, but it's completely failing to compress because it's full of clot. Okay. So for that particular patient, there's probably in the past there would have been about 3 points where I would have considered transferring that patient to the city for further investigations. But at each of those stages, then having access to clinician-performed ultrasound saved a journey for that lady. Okay. So why? Why is it a good idea? Well, I mean, for me, this is the biggie. We have pretty limited access to other imaging. I mean, things have changed a bit now, and I actually do have CT some hours of the day, some days of the week, and have ultrasound often during work hours. But certainly outside those hours, we have nothing. And I suspect that for a lot of people working in urgent care, that may be the same issue, and it's okay. Another real biggie is the quality of the technology. Used to be that these machines were large, very expensive, and quite delicate. You know, you could drop a probe and that was $17,000 sort of down the drain for a new probe. Nowadays, you know, I can attest to this, you can drive over them with the trolley. You can knock them around and they'll survive. The other thing as doctors that we really need is we need a simple machine with not that many knobs on it, and a machine that does a lot of the thinking for itself. And they do now. A lot of the clinician-performed ones do exactly that. Okay. If you want to buy a really good machine that's going to allow you to do echo, and it's going to be pretty reliable and give you all the bells and whistles, then you're probably looking at about 70K. Okay. But you can probably pick up something which is going to do a lot of what you want to do for probably 15K nowadays. And the prices are coming down all the time, rapidly. The other thing is the alternative for most of these things is not formal imaging, for most of us in the situation we work, it's physical examination. And relative to physical examination, listening, feeling, those sorts of things, it's infinitely more reliable. Okay. The evidence is pretty good now, particularly within the emergency medicine literature. It's proven to be safe, and it's proven to improve patient outcomes. Okay. I already mentioned procedures, but it makes an enormous difference to those procedures we used to do blind. And I think in a lot of situations now that this is almost a requirement that you undertake some of those procedures under ultrasound guidance. Okay. What are the arguments against it? And you'll certainly hear this, particularly from our radiology colleagues. And they're valid arguments. The first thing is, how can we possibly learn in a few weekends something which has taken a sonographer 3 years or more to learn full time? I mean, that's very valid. Okay. Another issue is the quality of the images that we obtain. The machines we use aren't as good. Our ability to adjust those machines to give the right images aren't as good. Our patients often aren't starved, they're often in pain and moving around, and so therefore invariably the image quality that we get is really quite inferior compared to that which a sonographer will get. Okay. There's always this concern as well too, particularly from perhaps our radiologists and specialist colleagues. Okay. I suspect this is a big issue, particularly in general practice and probably in urgent care as well. If a procedure like this is going to take 10, 15 minutes and you've only got 10 to 15 minutes to see the patient, then is it really practical? Okay. I think there's a couple of really important points that come out of that. I think the first thing is that we can't pretend that it replaces formal ultrasound and echo. And we can certainly probably reassure our colleagues who do this sort of work that it's not going to reduce the number of referrals they get. In fact, the ones at my work will say that probably it's increased the number of referrals that they get. A sonographer or an echocardiographer does a formal, thorough regional examination. But this is a really important point probably about clinician-performed ultrasound, is that we don't. So we don't do a formal examination of the upper abdomen or of the heart or of the pelvis. What we do is that when we pick up that probe, we are answering a single clinical question, which is usually a binary question. It's usually a yes-no question. And I think the whole thing around the safety of clinician-performed ultrasound is being absolutely certain that you know in your head what that binary question is before you pick up the probe. And if you do that, then I think you're much less likely to run into trouble. Okay. Where's it the most useful? It's the simple stuff often. Bladders, just fantastic for bladders. I'm sure it saved an enormous number of unnecessary catheterizations in our workplace. In my workplace anyway, particularly with elderly patients who present with abdominal pain, the thing that's critical that I don't miss, given that I'm so far away from a vascular surgeon, is a triple A. And if I can rule that out simply and quickly in the middle of the night, then that takes off a lot of pressure when it comes to working out what's wrong with that patient. It makes me much more comfortable about keeping them where I am, which is a long way from surgeons. I'll come back to this one. I think it's particularly helpful in undifferentiated shock. Okay. I think it's very helpful in acute significant deterioration in renal function, where we're trying to determine whether or not there's an obstructive cause for this, or whether or not it's a pre-renal or hypovolemic cause for it. Very handy. Okay. It certainly has a role here, and in EDs, it's probably where it gets its most use. Okay. Again, in my situation, knowing that there is an intrauterine pregnancy present, and therefore I'm extremely unlikely to be dealing with an ectopic is very handy. It's quite important here as well, given that particularly that the management of heart failure with preserved ejection fraction is completely different to the management of heart failure with reduced ejection fraction. We talked about procedures. These ones here I sort of added, and I wonder in your situations, sometimes it might be particularly helpful with these sorts of things, such as dealing with abscesses and foreign bodies. Okay. This is based on a bit of work we did in my context, and this is what the ultrasound gets used for most commonly where I work. IVCs, gallbladders, echoes. The next list is these ones are a little bit further down the list, but from what I understand, these next three are actually probably the ones that's used most often for in emergency departments, and that may well be the case in urgent care clinics as well, those next three. And then there's the rest of the list. Okay. I know in urgent care you guys have got a registrar program now, don't you? You've got some registrars coming through and stuff like that. Well, in rural hospitals we've got that as well. By far the best thing about that is that I get to go biking at lunchtimes now that I've got a registrar, and I never used to. And we've got really good biking at home. I want to talk a little bit about some of the areas where ultrasound is very useful and it's not where, and a sonographer wouldn't use it for. You know what I mean? So this is outside the scope of traditional ultrasound. And one of the great ones is fractures. Okay, so this is very easy to see, and it's a rib fracture, not visible on X-ray. So previously we were just a clinical diagnosis. When it comes to our Colles fractures where I work, we would all reduce them now under ultrasound. Still get a final check X-ray, but the actual reduction would be done under ultrasound guidance. Another area, again, which is not part of traditional ultrasound, is around volume assessment. And I find this very, very helpful where we work. I mean, a lot of what we do now, particularly with elder patients, is we muck around with their homeostatic mechanisms to maintain their volume. So we're giving them diuretics and a whole heap of other things which are going to interfere with that. And being able to assess their volume, particularly serially and over time, is very, very helpful. The way we look at that is with the JVP, or even more commonly with the IVC. So this is a patient, this one's actually a postpartum hemorrhage, this lady, and this is her IVC. Now that should be about 1.5 centimetres and not collapsing, but it's just completely collapsed completely. And it's very helpful to monitor her fluid resuscitation using the ultrasound. So here she is having had a litre of fluid, and you can see that even after 1 litre you've started to get quite a good response in the IVC. You can say that her volume is still down, but nothing like what it was. Lungs. I mean, I think most sonographers will look at you pretty oddly if you said that you were using ultrasound to look at lungs, but it's really helpful in lungs. Okay, and this is a normal lung, and this is normal sliding sign. So you can see sort of, here's the pleural line, and you can see as the patient breathes, you can see the visceral and the parietal pleura moving against each other. You can see this movement in this line. Okay. But in this patient here, again, here's the pleural line, but that's gone completely. So this patient's got pneumothorax. You can guarantee that they've got a pneumothorax.
What is that shadow, though? It's not an empty space which you'd expect in a pneumothorax.
No.
Do you know what I mean?
Below this, yeah. I mean, first of all, these are rib shadows. So this is the lung that you're looking at in here. You can't see lung. You can't see lung because lung is ear. So you can only really rely on artifacts and things like that to tell you about lung. So this is not lung. This is actually artifact. This is an ultrasound artifact below that line. There are times though when you can see the lung, and that's abnormal. Okay. And ultrasound is a great way of looking for pneumonia. So in this situation, this is lung tissue in here, and that's consolidated lung, just sitting above the diaphragm. So the evidence now is that ultrasound is probably much more sensitive when it comes for looking at lung consolidation than is traditional X-ray. And there's a couple of guys at work now who are really hot with this. And when it comes to differentiating cardiac failure from infection and things in the lungs, they're much more reliant on their ultrasound than they are on the ordinary chest X-ray. Okay. So, one of the nice things we have about home is the fact that winter's not too far away. It's the sort of best time of year for us, but you still do get to go biking and then skiing. That's the hill behind home a little bit later in the winter. Pitfalls. We've done a bit of a major audit, really. It's a research project, but it's really a major audit, looking at the use of ultrasound in rural hospitals in New Zealand. And it's pretty helpful when it comes to defining a safe scope of practice, I think. Okay. So these are the things that are easy. So basically, 100% of the time, the doctor looks at the bladder, they can get a diagnostic quality scan. These are things that are hard. Looking at the pelvis, gall bladder, echo. And these are things that are sort of somewhere in the middle of it. Okay. But it's not infrequently that you will pick up the probe, you won't get a diagnostic quality scan, and then you just give up, just go back to your basic clinical history and physical examination and things. We ask sonographer and echocardiographer to look at the image quality of what was being obtained, and you know, they told us that probably 10% of the time the images were of inadequate quality, and 6% of the time they were just completely non-diagnostic. They couldn't make a call at all on them. So, I mean, this sort of stuff tells you that it's not easy. And this is our ability to interpret images as well. And again, you know, this is pretty problematic. From our point of view, though, it's probably more helpful to know what scans are useful and what scans are hard. And again, the work that we did was a bit helpful when it comes to this. So essentially, this is if the doctor picks up the probe, so a real doc picks up a probe, and they think there's a AAA present, then they're right just over 3/4 of the time, but there's a bit of a tendency to overcall it. That's almost invariably because the aorta can be a bit tortuous, and if you cut it obliquely, then you will get measurements greater than are actually there. Okay. But if we think there's a AAA present, then there's always a AAA present. Okay. Oh, sorry, if we think there's no AAA there, there's no AAA there, I beg your pardon. So the specificity's got some problems, but the sensitivity's really high. Sorry about that. Which means that it's a really good rule-out test, and which is exactly what we want for that problem, isn't it? Okay. Bladders, like I said, easy. Always get it right. Fast scans. Yeah. There's it's a good rule-in test. So if we think there's free fluid present, then invariably we're right. But we've got a bit of a tendency to occasionally miss it. Now, it's a situation where we actually want a really good rule-out test. And so therefore fast is definitely problematic in that situation. What we did as part of the study is we did a pretty thorough notes review of all these cases as well too. And we had a set of criteria, and we determined whether or not the CPU had some or a significantly positive impact on patient care. And not surprisingly with fast, because of this, we found that on the odd occasion we felt that it had probably a detrimental impact on patient care. Okay. Gallbladder, not too bad. Measuring the thickness of the gallbladder wall, not very good. Kidneys, got again a bit of a tendency to overcall it, okay, which is not surprising because someone's got a full bladder. Then it often can look like the kidney's slightly hydronephrotic when in fact it's not. Okay, but almost invariably, if we think it's a normal kidney and there's no hydronephrosis, then we're right. So again, it's a pretty good rule-out test. Soft tissue stuff, and I imagine this would be quite useful for you guys. It's really reliable for soft tissue. Echoes, getting harder. When we start to look at regional wall abnormalities, really hard, get it wrong a lot of the time. And valve problems, again, we're pushing our limits. One of the things we tend to get wrong most often as clinicians is when we're dealing with sort of hollow organs or cylinder or the walls of organs, because we have this tendency to not realize we're cutting things obliquely and getting it wrong as a consequence of that, and that's the main reason that we get this one wrong a lot of the time. If we're doing stuff outside our recognised scopes, then again we're getting it wrong a lot of the time. So, basic rules. Some things are a lot harder than others. You've got to know what's hard.
Sorry, I saw earlier you said there was pelvic scans that was like 13% straight. Was that mainly for
Yeah. If you break it down and look at it really quite carefully in terms of individual cases, then we're pretty good at recognising an early intrauterine pregnancy. So if we stick to that, and only to that, then I think we're pretty safe. Yeah. But immediately people start looking any further than that, then they get into real trouble. Yeah. And when we looked at it, particularly if people start to think that they can look at ovarian things like that, no. We've already mentioned this briefly, but if you get to the point where you're just not getting the image quality, you don't push on, you don't pretend you can see stuff that you can't see, you need to just be realistic about it, put the probe aside and return to your basic clinical assessment. It's a really important one. This is where people really get into trouble. Vague abdominal pain, oh, just have a look with the ultrasound, just get the probe out and have a look around, see what I can see. Bit of a fishing expedition. That's serious trouble. You've got to know in your mind, you've not got to know that question that you're trying to answer. And the question's got to be, do they have gallstones or don't they? Do they have a AAA or don't they? Do they have free fluid or don't they? Okay. Already mentioned that being aware of the oblique beam. That tends to cause us quite a lot of trouble. This is a really important one as well too. Yeah, so if you're cutting a cylindrical, if you're sort of looking at a cylindrical structure, sort of such as the aorta, and you cut it obliquely, so rather than cut it directly across, if you cut it obliquely, then you'll get a false measurement. So it may look on the screen like you're dealing with something which is wider than it really is. Yeah. And it applies to, say, the wall of the gallbladder or a lot of other things. And this is really important. I mean, patients don't know this. They think that we're doctors and that we know more. Right? They've got no idea how much better that sonographer is than us. And it's a real risk that they will, and they do this. They'll go to the, because our sonographer and our echo tech tell me, they'll go to them and they'll say, oh, you know, it's okay, I've already had this done. You know, Gary did this a few days ago. Oh, it's very frustrating to the sonographer to hear that, and they sort of, you know, but they need to know what we can do and what we can't do and the limitations of what we're doing. For DVT, it's reasonably good for above knee. It's probably beyond most of us for below knee. Yeah. And also don't ignore the unusual too, because occasionally you will see stuff which is completely out there that you need to go and send for a formal scan. And my best one I think ever of that was, does anybody who's used ultrasound can see what's wrong there? This is an elderly lady who had had a long illness which had been investigated by a whole series of specialists who come in with what looked like mild heart failure, and we had a look. It's actually, the problem's actually that there. She's got a golf ball in her left atrium. She had a left atrial myxoma. So it's quite neat to be able to phone up the cardiothoracic registrar and say, I've got a patient with a left atrial myxoma. The country to the west of home is sort of even more pretty and more impressive than actually where I live, and this is en route to the Olivine Ice Plateau out to the west of us and closer to it, and that's the Mount Aspiring looking through the Olivine Ice Plateau. Okay, so how are we going for time? We've still got a bit of time, haven't we? How much more have I got? Another 5 minutes or 15? Oh, okay, good. We'll have time at the end for some discussion too. Yeah. Yes. 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 You can only see the one surface. You can only see the periosteal surface that you are looking at. Yeah. Yes. Yes. Do both. Do both. Mm. If you're reducing a fracture, like a Colles fracture, then I think you still need a check X-ray after you've completed it. Yep.
So like, can you say, listen to your, this is what I say with also, and you check it, just
Yeah, yep, you can. So in the past, what I would often do if I had if I was unsure about it, then I would get a quick check X-ray before I took the cuffs off. I use a Beers block. I don't know if you guys, yeah. So I would do that before the Beers block. But I can be confident enough now, looking with ultrasound, to say that actually the Beers block can come off, and we'll get the check X-ray done after that. It's pretty good. Yep. Yep. 15. Okay. I'm going to just use it to talk about one particular sort of clinical scenario, I guess, where I find it particularly useful, and that's a patient, and it's often an elderly patient, I have to say, who presents generally unwell with a slightly lowish blood pressure. It's pretty common, I think, you know, and the differential is enormous, isn't it? I mean, have they had an MI? Are they septic? Are they dry? Have they had a pulmonary embolus? Is it a primary cardiac problem? Is it pericardial effusion? Enormous differential. And I think it's particularly useful in assessing that sort of patient. And then in this situation, it's very tied to your ongoing clinical assessment of that patient. So I've got just 2 or 3 examples of that. First one's a 57-year-old man. He presents with a day of chest tightness. He's got elevated troponin. He's got T-wave inversion and a resumed acute coronary syndrome. So that's his ECG. I think people will be able to sell that patient to a cardiologist with an elevated troponin. I wouldn't be too hard. I think the cardiologist would look at it and say, oh, he's got a lesion in his proximal LAD, I think they'd say. Okay, but this particular patient sort of had a bit of trouble finding his JVP, which I certainly with our registrars anyway, I try and instill in them, which is that is the most important part of the physical examination, is a good evaluation of the JVP. Okay, and in this situation we looked at his inferior vena cava, and that's his IVC. So it's about 2.5 centimetres, and it's big and it's bulging, not collapsing at all. So anybody got any other ideas about what? Should we still talk to the cardiologists? Sure. Pardon? So going to have a look at the heart. Yep. And that's the heart. Yeah. So you're exactly right. So this is the right side of the heart. It should be smaller than the left side of the heart, just like the first one I showed you, but huge, big, box-shaped right ventricle. So no doubt about it, it's pulmonary embolus, as this guy's had.
You actually said it was bulging in the first ultrasound. You said it was bulging. Did you mean that you couldn't compress it?
Yeah, no, I mean, probably it's particularly around the apex. So if you look at the apex here, the right ventricle should be quite crescent-shaped, and it should be quite narrow out at the apex, out here, and then should sort of come back round. So the fact that it's sort of blown out and almost box-shaped at the apex is indicative.
This ultrasound of the IVC.
Oh, I see. Sorry. You can't compress the IVC. No, you can't.
So it just looked bigger than it should be.
Yeah, look big, and you would normally follow it through at the respiratory cycle. So you would normally see that it would collapse about 50% with respiration. So the fact that it was big and fixed. Yep.
So would you call that right ventricular strain?
Yep. Definitely. Then it raises that whole question about thrombolytics, doesn't it? Yeah, but we won't get into that. Okay, so here's another one. This is I think a gentleman in his 70s, sort of attending a local bowling tournament, had 2 episodes where he stood up and passed out. And that was his ECG. Okay, and sorry? Yeah, it's a tachycardia. I was certain I knew what was wrong with the patient when I saw that ECG. I didn't have any doubt in my own mind what was wrong with him. People were prepared to make a diagnosis of that ECG. I thought I was really confident what it was. So 70s, never had problems with arrhythmias in the past. That ECG. Certainly narrow complex tachycardia. Can't see P waves, can you? Sorry? Yes. Well, I don't think it'd be unreasonable to say SVT, but he never had it before or anything like that. And I actually was really confident I could see flutter waves. See one there, the end of those T waves. And if you map them out, the second flutter wave is sitting in the QRS. It's 2-to-1 conduction. It didn't have any doubt in my own mind that that's exactly what it was. Okay. But I couldn't see his JVP. It was cardiac problem. I expected at least to be able to see his JVP. So I had to have a look at his JVP with ultrasound. Now, ultrasound is actually really good for looking at the JVP. It's excellent. It's very easy. And this is him lying flat. That's the carotid, and that's the internal jugular. Someone lying flat should have a big, bulging JVP. But the fact that that's flat means it's completely empty. So that just didn't make sense. So that's a quick look at his IVC. Now, in fact, this is his heart, and this is his IVC coming out of his heart. You can hardly even see it. It's so empty. It's flat. So he was hypovolemic, really hypovolemic. You know, I looked at that first ECG. I was tempted to, give him a dose of Clexane and try some amiodarone and see what we can do. In the end, this guy had a GI bleed. I mean, he denied melena. Even when questioning, he denied melena. So only did a PR that there was melena on the glove. So that was his problem. And his ECG, first ECG, interestingly enough, was actually sinus tachycardia with first-degree heart block. And those what I thought were flutter waves, once you lengthened out the cycle, they sort of appeared as P waves with a long PR interval. Okay. So I mean, ultrasound completely saved me in that particular situation. Okay, and that's his heart. And that's again a classic look at someone's at a hypovolemic heart, hyperdynamic, just absolutely pelting away, strong and healthy, but going hell for leather. And it's the sort of appearance you get in a septic patient as well too.
What was his blood pressure?
It was about 100. Yeah, it was down slightly. This one was not too long ago. A 60-year-old man, he'd involved in a motorbike accident and a compound fractured femur. We just got one person at work on after hours and things like that. So they got this guy and had a pretty difficult first 20 minutes or so with him. Gave him a couple of litres of fluid and got no response. His pulse just disappeared and his blood pressure faded away. So so in those situations we call a second person. We don't have someone on call, but we just phone around. And I come in and had a bit of a look. By the time I saw him, he was the odd groan, but you couldn't get a pulse or a blood pressure. So first of all, ultrasound straight to the abdomen. That's his IVC. What do you think of that? It's pretty different to that one that was hypovolemic, isn't it? It's big and dilated, huge. So it's not hypovolemic, is he? So where do people want to go with the ultrasound probe next? To the heart. Yeah, go straight to the heart. When you wouldn't even think about it, go straight to the heart. And that was his heart. So people, again, it's barn door, pretty easy to see. So you've got a, I'll go back. Okay, get this right again. So this is his heart. Huge pericardial effusion, so he's bled into his pericardium. Okay.
Did he have contusions to his chest? That includes like that?
No. No, there was very little to see. There was no obvious contusions to the chest. Pardon?
What do you do with them?
Well, again, because we got ultrasound, it makes life a lot easier. We'll put a drain in.
What do you mean, needle therapy?
Yeah. We do keep a pericardial drain at work, so we used a pericardial drain.
It worked then?
Yeah, it worked like magic. So you can. So there's actually it's pretty hard to see. This is not very good. That's actually the drain in there, sitting in this pericardium. And I mean, he was, by the time ICU team come from Dunedin to pick him up, he was as right as rain. He was good. Okay. Just briefly, when it comes, yeah, sorry.
How do you document these patients' notes? Because you see it, you don't keep a record.
Yeah. I think we're probably really bad at that. We do have a system at work whereby each of us has a records on the machine the name of the patient, the NHI, and our own name. And then once a week, an admin person comes and downloads all the saved images and clips and puts them into a file. So there is records kept. And then some of us will maintain a logbook. We'll write each ultrasound that we do. And we do have, once every 6 weeks, we have a peer review session where there's a sonographer and an ecotech will spend a bit of time with us looking at images. Yeah, but I think that's very important to do that. Yeah. But I understand that in some places that's not the case. But for me, if, doing this without recording images and things would be like sort of doing a physical examination, taking a history without writing notes. I don't think it's the right thing to do. Yeah. There is a qualification that we run out of University of Otago. And I think there's a few urgent care doctors, Calvin and some others that have done it and hopefully found it reasonably useful. And I'll tell you about it briefly. That's not because we're looking for students, because actually this is by far most oversubscribed qualification that we've got. But and most of the people doing it nowadays are ED physicians and quite a few anaesthetists and stuff as well, actually. Which is a little bit unusual that they're coming to a program that's come out of a real generalist department to learn these sorts of skills. I always find that a little bit ironic. But we do give preference to generalists who want to enrol in the program. And it includes 2 papers which are run concurrently. You have to do both papers. You can't just do one of them because they're very much taught at the same time. The components of it are, first of all, we start with Ultrasound Physics, which is the real fun part of the course. It gets really good ratings, Ultrasound Physics. So it's a matter of going back and trying to remember all that stuff about waves and vectors that you learned in 6th form physics and relearning it. Now, that is actually really, really important. A huge chunk of what you see on an ultrasound screen is not real. It's artifact. Unless you understand that and they can tell what's real and what's not, then you will get into real trouble. So we don't apologise for that. That is necessary. Okay. Again, it's a hands-on thing. So it's got to be practical. And so there's 3 residential workshops which run over the year, and each one of those is 3 days. I know some places try to teach it in a single week-long course, but we very much found that by the end of 3 days, people completely had enough. That was as much as they could absorb. And as soon as they went away, then they sort of had more questions again. So that's why people come back for those 3 occasions. And then we use some online teaching as well. Okay. The curriculum, that's the way the curriculum's written. And as you can see, it's written in those questions I was talking about, isn't it? So we don't teach people to do the gallbladder or anything like that. The question is, are the gallstones present? And that's the way the curriculum's presented. And it does include some procedures. And this is what we were talking about a little bit before, wasn't it, as well? Those systems of audit, keeping records, that sort of thing is very important. And that's about right time-wise, isn't it? I see any questions? Yeah. Yes, so what I do is I will write in the patient's record. I'll write a record of the findings. Yeah. Yes, always keep the images as well. Yeah, always. And like I say, we've got a system of those images being downloaded off the machine once a week and then actually put into a file. Yeah. They probably should go onto the PACS. They probably should go, where all the other imaging for that patient is. But we're not up to speed with that yet. Yeah. Oh, yeah, we don't have any surgical registers around. Probably initially a little bit. I think sometimes when the retrieval teams come up initially, they're a little bit unsure what was happening. But no, I think they're pretty au fait about it now. Yeah. We would generally, at best, we would have 2 medical staff at a significant trauma. We wouldn't have any more than that. So even you can't afford to have one person just scanning. It's got to be a bit intermittent. Yeah.
How many years have you been doing it, by the way?
Don't know. Probably about 12 or 14, 15 years perhaps. Don't know. I've done it a while, but I mean my skill is nothing like a sonographer or an ecotech. Yeah, and I've played around a little bit with some of the really tiny handheld ones, and the modern versions of those are pretty good. You know, you're not going to be able to do a formal cardiac scan and that sort of thing, perhaps do as much with that. But like I have to say, you know, especially for superficial work or a quick look in the right upper quadrant or something like that, you know, they're pretty impressive nowadays. Yeah, and getting cheaper. Great. Thank you.